Sometimes the most dangerous diagnosis in male infertility is not azoospermia, not varicocele, not hormones. It is one word that makes doctors stop thinking: idiopathic. Meaning, we looked but we didn't see. Today, we will see what routine workup miss and how to treat idiopathic male infertility like a real disease. By the end of this Talkflix episode, you'll have a working clinical protocol. And we've had two episodes before this, which you've got to see: semen analysis and oligospermia. And following this, I have come to idiopathic male infertility. So, what all will we have in this? Number one, how guidelines define idiopathic male infertility, why such a large fraction still remains unexplained, the real biology behind it, oxidative stress, DNA chromatin damage, inflammation and metabolism, why add-on tests can help when the story and semen report don't match, a structure, time-bound, empiric, medical therapeutic plan, and when to stop and move to ART without wasting time. See, let's come to the definition first. Idiopathic doesn't mean nothing. It means after standard evaluation, history, examination, semen analysis, and targeted endocrine and genetic tests, no clear etiological diagnosis is found. So, idiopathic is not a diagnosis of peace. It is a diagnosis of our current tools are not enough. Now, the other question comes is, how common is it? Roughly 1/3 of infertile men, often quoted as 30 to 40%, fall into this idiopathic bucket despite proper workup. So, if you run a busy infertility clinic, idiopathic is not rare, idiopathic is everyday. Why do they say idiopathic? Because routine tools don't routinely measure the molecular layers. What all is it? Oxidative stress and redox imbalance, sperm DNA fragmentation and chromatin packaging defects, subtle genetic or epigenetic issues, low-grade inflammation. Metabolic and functional endocrine dysfunction: a man can have acceptable numbers, yet carry molecular damage that blocks fertilization, embryo development, and increases miscarriage risk. So, what happens is the count is normal, everything is fine, you say everything is great, but pregnancy is not happening. And you know what it turns out to be? Idiopathic. So, let us now just talk about the mechanism. So, idiopathic stress is not a buzzword, it is a pathway. Excess ROS leads to lipid peroxidation, mitochondrial dysfunction, loss of membrane potential, and apoptosis. And the sperm loses motility and fertilizing capacity. So, what I exactly have said to you at the moment is what is happening in every day, and the modern life which we're leading is increasing it. Then comes the invisible fractures, the sperm DNA fragmentation and chromatin damage. ROS plus defective chromatin packaging equals a fragile genome. That's why couples can have repeated IVF failures or recurrent loss even when the semen report looks not to be bad. Now, add inflammation and silent infections that keeps the genital tract in a pro-oxidant state, add immune microenvironment changes inside the testes, add metabolic diseases like obesity, insulin resistance, diabetes, where hormone can still appear within range, but biology is clearly dysfunction. मोटा मोटा जो नज़र में आपको नज़र नहीं आ रहा, उसका नज़रिया आपको बनाना है, जिससे you know exactly what is going on deeper. Sometimes the report doesn't give you the correct thing, but it gives you a signal. Now, what can we do? Guidelines consistent and clinically honest. So, empirical medical therapy is allowed in idiopathic cases, but it must be structured, not random. So, the goal is simple. Number one, to improve sperm biology. Number two, to reduce oxidative stress. Number three, to improve DNA integrity and use this time wisely. So the main pillars are, number one, lifestyle optimization. You've got to look after your weight, smoking, alcohol, sleep, stress, and heat exposure. Number two, antioxidant therapy or strategy, which has to be time bound and monitored. Number three, selective endocrine therapy when indicated. See, it's never a blanket tonic. Important warning is more antioxidant is not always better. However, giving the right dose for the right time, till the right time, which may be a mixture of antioxidants, is the greatest thing to do. It's not to be too much and unbalanced, because it can lead to a reductive stress which may impair sperm function. So antioxidants are like small fire cooks food, but the fire needs to be okay and the food needs to be okay. Now, when should you consider add-on tests? When clinical story and semen analysis don't match. Now, this is very important. I'm asked by a lot of people always that the semen analysis is fine. What can we do? And I'm asked by doctors as well as by patients. So I've got to look for a few things which I normally look. I look at recurrent implantation failure, recurrent pregnancy loss, unexplained infertility with near normal semen parameters, persistent idiopathic infertility despite a clean basic workup in those scenarios, adjunct semen DNA fragmentation testing, and oxidative stress or redox tools can help me guide to this decision. Now, it's very important, but more important at this time also is how long should you treat before escalating. Now, let us think about biology. One full spermatogenic cycle plus transit is the time you need to take. So at least 3 months before you judge a response. Now, what do I practically do? See, I start a structured therapy for 3 months. It could be one antioxidant. It could be a mix of antioxidants. In the correct dose, I would reassess. If it is improving, I would continue for 6 months. If it is not improving, or if the female age ovarian reserve demands speed, I stop guessing and go on to assisted reproductive technology, or ART as we call it. Now, hard stop rules is one thing. If the age is more, if the sperm count is low, please move on to ART. Now, what is the dictum which I normally follow? If there is no improvement in 3 months or it is worsening, if the female factor demands speed, if there is severe baseline sperm abnormality, and there is prolonged infertility duration, because in fertility, the biggest complication is not side effect, it is time. Now, the final message which I'd like to give to you is empiric therapy is not anti-ART. A lot of people think that they are giving this therapy and they should take the patient up for ART. It is complementary at times. It's ART's best friend when used correctly. Use empiric therapy to improve biology. Use ART strategically, and remember, idiopathic does not mean no problem. It means go one level deeper. It's been a pleasure to talk about idiopathic because I've had a couple of international publications on this, and I really would like to share these with you, which could be. Why? Because everybody as a clinician needs to know about empiric therapy. And the first 2 episodes, link this episode over here, and the next episode which will be there will be beautiful for you, because I'm in He Matters only on Docflix. Now let us remember that idiopathic does not mean a problem. It means we need to go one level deeper. It's the 3rd episode. The first 2 episodes were semen analysis and oligospermia. And you know, the next episode is something which 1% population has. Well, that's the way it is. Azoospermia. We're going to give you a beautiful paper. And this paper is a paper completely done international on sperm DNA fragmentation and on idiopathic male infertility. Read this paper. It's really going to help you, because we are on He Matters only on Talkflix.